Acute pharyngitis, or sore throat, is one of the most common medical complaints of adults and children, accounting for over 15 million doctor visits a year in the United States. Pharyngitis, often viewed as a mild infectious problem with minimal consequences, can be the presenting symptom of several serious conditions. An extensive list of infectious and non-infectious causes exists for pharyngitis. In the pre-antibiotic era, deaths related to acute pharyngitis and its consequences, abscesses, septicemia, airway obstruction, and others, were common. Those conditions may still occur, especially if patients do not receive appropriate medical treatment in a timely manner. Controversies regarding diagnosis strategies and the role of antibiotics in the management of acute pharyngitis still exist. All physicians caring for patients with acute pharyngitis should be familiar with the most recent paradigms in patient management and should remain alert for serious conditions that may present as sore throat. Severe infectious processes can present with acute oropharyngeal symptoms. Thus, the first priority in the evaluation of a patient with symptoms of acute pharyngitis is to consider and rule out life-threatening causes. Because pharyngeal discomfort is so common and usually fairly benign, some physicians tend to take sore throats less seriously than they should. One consequence of this error may be preventable death. Relatively benign-appearing pharyngitis may also herald a more fulminant infection in immunocompromised patients. For example, sepsis requiring hospital admission and intravenous antibiotics has been reported in splenectomized patients with only mild pharyngeal signs. Therefore, a high index of suspicion, prompt culture, early treatment, and close follow-up are essential in immunocompromised patients with clinical features of mild pharyngitis. Most of the oral pharyngeal bacterial infections are caused by gram-positive aerobes, although mixed infections with anaerobic organisms such as Streptococcus, Fusobacterium, and Bacteroides species do occur regularly. One of the most frequently implicated species in bacterial pharyngitis is Group A beta hemolytic streptococcus, GABHS. Strep throat usually occurs in children during the winter and spring months. Patients typically present with sore throat, dysphagia, and fever, which are often accompanied by cervical adenopathy and pharyngeal exudate. The erythrogenic toxin produced in some streptococcal infections can cause scarlet fever, marked by a classic rash that spares the palms and soles. Appearing 1 to 2 days after the onset of pharyngeal symptoms, the rash may be accompanied by a red, swollen, mottled, strawberry tongue. Systemic manifestations of scarlet fever are rare in the modern antibiotic era, but may occur in patients who do not receive adequate doses of appropriate antibiotics promptly. Other complications of streptococcal infection, including rheumatic fever, rheumatic heart disease, and glomerulonephritis, are also rare today because of the appropriate use of antibiotics. Even though most pharyngeal signs are nonspecific, the presence of exudative pharyngitis with fever and adenopathy without other symptoms of upper respiratory infection is predictive of GABHS-positive cultures in at least 50% of patients. The rapid streptococcal test specific for a GABHS carbohydrate antigen and throat culture are the most commonly used diagnostic tests. A positive rapid streptococcal test result is as reliable as a positive culture finding, but a negative result should be confirmed by a throat culture. Cultures may be positive in carriers without active disease. Although no penicillin-resistant strains of GABHS have been identified, some evidence exists that concomitant infection with other B-lactamase-producing organisms may confer relative resistance. Many medical authorities are concerned that the indiscriminate use of antibiotics will increase resistance patterns or allergic reaction rates. Therefore, prescribe these drugs judiciously rather than routinely for pharyngeal symptoms. However, when clinical suspicion of strep is high, most accepted treatment protocols require performance of a rapid streptococcal test and the administration of antibiotics before the results are known. Continue treatment with antibiotics for 10 days when the culture is positive, and discontinue medication if the culture is negative. Dosage varies by factors such as age and body weight. Given within the first 24 to 48 hours of infections, antibiotic treatment against GABHS reduces the risk of rheumatic fever and infection spread complications, and decreases the duration of symptoms. Waiting for a positive result is recommended only when clinical suspicion is low, in which case symptomatic treatment should be offered. A survey of several hundred pediatricians showed that the majority used oral penicillin V as the primary antibiotic in strep throat. However, intramuscular benzathine penicillin G was as effective and resulted in better compliance. Second-tier antibiotics include penicillin derivatives and cephalosporins, such as cefadroxil, cefaclor, and cephalexin. These same medications are appropriate for children and adults. Other bacterial pathogens also can cause pharyngitis and require antibiotic treatment. Staphylococcus aureus infection is characterized by mucopurulent discharge, localized edema, and erythema. Pustules, commonly localized to the tonsils, may also be present. Pneumococcus and Haemophilus bacterial strains also cause pharyngeal erythema and edema, but not an exudate in most cases. The choice of antibiotic therapy is often determined by regional resistance patterns and should usually be guided by culture and sensitivity testing. Bordetella pertussis infection, pertussis, a rare childhood disease in developed countries, can present with pharyngeal signs, fever, and other upper respiratory infectious symptoms. After the early stage, which lasts 1 to 2 weeks, the disease progresses to a paroxysmal stage, which is manifested by a mucopurulent discharge and the characteristic whooping cough. The convalescent stage follows 2 to 4 weeks later. Despite the prolonged nature of pertussis, it is usually self-limited. Sexually transmitted diseases must also be considered in the differential diagnosis of pharyngitis. Syphilis, a systemic disease caused by Treponema pallidum, can have many head and neck manifestations. After initial exposure and an incubation period, a painless solitary nodule appears at the site of the inoculation, which may be the pharynx. The primary lesion, which contains organisms visible by dark-field microscopy or other techniques, usually resolves in 3 to 6 weeks. The development of pharyngeal tonsillitis is not unusual in the secondary stage. It is characterized by highly infectious mucosal patches with red, raised margins and a silver-gray exudate, and can also occur in secondary syphilis originating from other primary sites. Serologic diagnosis with a rapid plasma reagin test, a fluorescent treponemal antibody absorption test, or another appropriate study may be diagnostic, but they may also produce false positive results in the presence of certain other systemic diseases. Penicillin remains the treatment of choice. Neisseria gonorrhea infection also can present with pharyngitis. Although gonorrheal infection of the oral cavity is often asymptomatic, pharyngeal signs such as acute sore throat, tonsillar hypertrophy, and lymphadenopathy may occur. The need for special culture media, chocolate agar, means that this diagnosis may be missed unless the physician has a high degree of suspicion of high-risk behavior. The pharynx can be the source of recurrent infections, systemic dissemination, and/or the spread of the infection to others. The treatment of choice is penicillin or tetracycline. Alternative treatments are not recommended. Many other bacteria can cause symptoms of pharyngitis. Although rarely dangerous in developed countries because of routine immunization, Corynebacterium diphtheriae causes diphtheria, a potentially fatal infection that must be considered in the acutely ill patient with pharyngitis. The patient appears much sicker than the physical findings would seem to indicate. Lethargy, fatigue, and tachycardia are often present. The typical finding is a grayish, firmly adherent membrane in the pharynx. The endotoxin released by the bacteria causes substantial tissue necrosis and inflammation. Extension of the membranous changes to the rest of the respiratory tract or systemic endotoxin release can lead to respiratory and/or cardiovascular collapse. Corynebacterium hemolyticum can also produce a membranous pharyngitis, although this disorder is usually less extensive and has milder systemic symptoms. Rhinoscleroma, uncommon in the United States but endemic in other parts of the world, is caused by Klebsiella rhinoscleromatis. This disease usually develops in the first to third decades of life. The first stage is characterized by a mucopurulent nasopharyngeal discharge and is followed by hyperplastic mucosal changes and the presence of laryngeal histiocytes, called Mikulicz cells, in the submucosa. Treatment usually consists of tetracycline and streptomycin. Diseases such as Actinomyces israelii infection and cat scratch fever usually present as adenopathy but can also manifest as pharyngitis. Other bacteria such as Salmonella typhimurium, Chlamydia trachomatis, Mycoplasma pneumoniae, and Coxiella burnetii, also called Rickettsia burnetii, to name a few, also have been reported to cause atypical pharyngitis patterns. Although rare, mycobacterial Pharyngeal Tonsillitis may occur as the result of expelled infected sputum from a primary pulmonary infection. Both Mycobacterium tuberculosis and Mycobacterium bovis can infect the pharynx. Mycobacterium leprae, the pathogen that causes leprosy, can cause pharyngitis that is usually secondary to nasal cavity involvement. Epiglottitis usually occurs in children aged 2 to 5 years, but can also occur in adults. This rapidly progressive inflammation of the epiglottis and supraglottic structures, usually caused by Haemophilus influenzae type B, begins with a sore throat, fever, and dysphagia. As the disease progresses, it may cause drooling, inspiratory stridor, and pain that is out of proportion to pharyngeal findings. When you suspect epiglottitis in a patient with an adequate airway, obtain a lateral soft tissue X-ray of the neck in the presence of a physician who is capable of securing an airway by intubation or emergent tracheostomy in the event of rapid and complete obstruction. The thumb sign, a broadening and flattening of the epiglottis, helps establish the diagnosis. Although contraindicated in children in whom epiglottitis is suspected, visualization of the supraglottic area in adults may be performed by a trained specialist. Several odontogenic infections can be the source of a variety of pharyngeal complaints. Ludwig's angina is the most acutely threatening. Easily distinguished from pharyngitis by the presence of submental tenderness and swelling, in addition to pharyngeal signs, the advanced form of this disease is characterized by severe trismus, drooling, and airway compromise. Tracheotomy for airway control and external surgical drainage is often required, along with antibiotic therapy for a mixed oral flora infection. Vincent's angina, or trench mouth, an acute necrotizing ulcerative gingivitis, can also inflame pharyngeal membranes. Signs and symptoms include oropharyngeal ulcerations, cervical adenopathy, low-grade fever, and fetid breath related to poor oral hygiene. Gram staining and culture show gram-negative bacilli, Fusobacterium, and gram-negative spiral organisms, Treponema. It is treated with penicillins. Improved oral hygiene can prevent recurrence. Additional odontogenic infections can lead to parapharyngeal and other deep space neck infections. Peritonsillar abscess, or peritonsillar cellulitis, its precursor, usually results from inadequately treated bacterial tonsillitis. Dysphagia, trismus, drooling, and fever typically develop 7 to 10 days after the onset of acute pharyngeal symptoms. Non-pulsatile tonsillar pilar induration and fullness progress to palatal edema with uvular deviation. Tonsillar erythema and exudate may be unexpectedly mild. Needle aspiration of the peritonsillar fluctuantes confirms the diagnosis of abscess. Treatment includes abscess drainage, which often can be accompanied by aspiration with a needle, typically in more than one location in the abscess area. In the absence of adequate treatment, this condition may progress to a parapharyngeal space abscess. CT imaging is very helpful in confirming this suspected diagnosis. The parapharyngeal space contains the carotid sheath, cervical sympathetic chain, and cranial nerves 9 through 12. Hence, the possibility of severe neurovascular complications necessitates urgent external drainage and antibiotic treatment. Severe trismus in these patients can make orotracheal intubation difficult, necessitating the availability of skilled airway management personnel. If not managed correctly, the inadvertent rupture of parapharyngeal or a retropharyngeal abscess during attempted intubation can lead to aspiration, airway obstruction, and death. Retropharyngeal abscesses may cause pharyngeal inflammation and pain, dyspnea, stridor, and a hot potato voice. If the patient is seen early in the course of the illness, pain may be the only presenting symptom, and pharyngeal fullness the only presenting sign. Pain referred to the posterior neck may also be a presenting sign. Many patients have a history of recent instrumentation during oral or dental procedures, foreign body insult, or other trauma. Physical examination usually reveals an acutely ill patient, often with fever spikes and an edematous, erythematous posterior pharyngeal wall. An apparent midline furrow caused by the midline raphe insertion of the pharyngeal constrictor can often be seen. Findings on nasopharyngeal fiber optic examination may be normal. A definitive diagnosis can be obtained from lateral soft tissue X-rays showing thickening of the prevertebral soft tissue, or from a contrast-enhanced computed tomographic scan demonstrating a fluid collection. Patients on anticoagulants may also manifest these signs without the febrile component in the presence of spontaneous retropharyngeal hematomas. Airway obstruction from pharyngeal abscess extension, aspiration from spontaneous or accidental intraoral rupture, and the potential for mediastinal extension all highlight the need for prompt treatment, which should include airway protection, surgical drainage, culture, and antibiotics. Because many viral pharyngeal infections can mimic bacterial infections, differentiating between these entities remains a topic of much debate. The distinction is clinically important because of the controversy surrounding the use of antibiotics based solely on symptoms. Mucosal edema and erythema are common to both bacterial and viral infections of the throat. Most viral infections, with the exception of those in immunocompromised granulocytopenic patients, are self-limited. Rhinoviruses and parainfluenza virus are among the more common causative agents of pharyngitis. Acute viral laryngotracheitis, or croup, may present in similar fashion to that of epiglottitis. Usually occurring in children younger than 5 years of age, croup tends to have more respiratory than pharyngeal signs. It is a seasonal disorder, and it is self-limited. The radiographic steeple sign narrowing of the subglottic airway on an anterior soft tissue X-ray of the neck is a useful diagnostic finding. Once again, X-ray should only be obtained in patients with a stable airway in the presence of a physician who is appropriately skilled in emergent tracheostomy. Treatment consists of airway support, intubation in some cases, humidification, racemic epinephrine inhalation therapy, corticosteroids, thinning of secretions, and antibiotic treatment of secondary bacterial infections. Laryngotracheal visualization should be performed in adults with symptoms of laryngeal inflammation, even if radiographic findings are negative. Echoviruses and Coxsackie viruses A and B cause ulcerative pharyngitis patterns. Adenovirus, another common pathogen, has been implicated in pharyngoconjunctival fever, as well as in simple pharyngitis. Rubeola, measles, which is caused by a paramyxovirus, may be associated with acute pharyngeal tonsillitis. Human papillomaviruses, HPV, particularly type 6, 11, 16, and 18, usually associated with benign, type 6 and 11, and malignant, type 16 and 18, papillomatous lesions, also have been linked to pharyngeal symptoms. Types 1 and 2 herpes simplex viruses can cause pharyngeal pain and erythema with both primary and secondary infections. Primary herpetic infections usually present as gingivostomatitis, but can start with pharyngitis, fatigue, and malaise. Bleeding vesicular lesions with crusts or exudates develop in the pharynx or tonsils. Mononucleosis usually presents with sore throat, fever, and malaise. The main causative pathogen is Epstein-Barr virus. Others are cytomegalovirus, Toxoplasma gondii, the toga virus that causes rubella, hepatitis A virus, and some adenoviruses. Mild to severe exudative pharyngotonsillitis and adenopathy are almost always present and are often accompanied by splenomegaly and hepatomegaly. Cytomegalovirus-induced mononucleosis is less likely than Epstein-Barr virus to produce pharyngeal symptoms. Treatment is supportive. Resolution usually occurs in a matter of months. Uncommon in non-debilitated patients, fungal pharyngitis is usually diagnosed easily by physical examination. Candida albicans is the most common causative pathogen. The infection often occurs as a complication of antibiotic therapy that disrupts the microbial balance, altering the oral flora, and commonly includes Candida. Pain and dysphagia occur in immunocompromised persons, and a cottage cheese-like membrane that bleeds after removal is characteristic. Topical antifungal treatment is usually sufficient unless the infection is part of a systemic infection. Sarcoidosis may affect the pharynx, larynx, and tonsils by producing submucosal granulomas at these sites with progression to ulceration and tissue destruction. Wegener's granulomatosis, an obliterative vascular granulomatous process, typically involves the sinonasal area, although primary pharyngeal involvement has also been described. Pharyngeal involvement is usually a secondary inflammation caused by the discharge associated with primary sinonasal disease. Crohn's disease, a granulomatous process primarily affecting the intestines, shows pharyngeal involvement in a small percentage of patients. Granulomatous changes in the pharynx may also occur in response to a foreign body. Such foreign bodies are often radiolucent on imaging studies and may pose a diagnostic challenge. Many systemic disorders can be accompanied by pharyngeal symptoms and signs. In Stevens-Johnson syndrome, painful vesiculobullous lesions often persist longer in the pharynx than on the skin. Many of the pemphigus diseases produce oropharyngeal manifestations along with skin lesions. The progression of pharyngeal disease often follows that of the overall disease course. Systemic lupus erythematosus may be associated with painful pharyngeal ulcers that usually vary in severity and duration relative to other symptoms. Scleroderma may be marked by oropharyngeal edema, followed by atrophy and indurations. Tangier disease, a lipoprotein deposition disorder, may be manifested by enlarged tonsils and yellow deposits. Recurrent pharyngitis may also occur in other non-infectious disorders such as allergy, gastroesophageal reflux disease, and some blood dyscrasias. A small number of patients have an idiopathic chronic pharyngeal irritation, but this is a rare diagnosis of exclusion made only after all other etiologies are appropriately excluded. Throat pain and dysphagia may be caused by local malignancy or may represent referred pain from other head and neck sites. Any patient whose pain does not resolve following 10 to 14 days of antibiotic treatment should undergo a full head and neck examination by an appropriate specialist. Head and neck malignancies can occur in patients of any age who may or may not have histories of cigarette and alcohol use. These malignancies may elude visualization on routine oropharyngeal examination. Pharyngitis is a common complaint with a very diverse differential diagnosis. Despite the many benign and easily treatable causes, it can be a symptom of underlying disease that, if missed, can have serious consequences, including death. Pharyngitis requires a history and physical examination, a thorough and thoughtful workup as indicated, and while many patients with pharyngitis can be managed by primary care physicians, patients with unusual presentations, complications, or who fail to respond rapidly to treatment should be assessed and treated by an otolaryngologist.